Urinary catheterization involves the placement of a tube, or catheter, into the urinary bladder via the urethra. Catheterization is one of the most commonly performed procedures in the hospital setting, and should be a familiar practice to all medical trainees. Urinary catheters have been used as a medical instrument since the times of Hippocrates, and today is considered an essential skill for all physicians to possess. Having an introduction and approach to catheterization can make the process less intimidating and make you more efficient on the wards. The indications for catheterization can generally be divided into two main categories: to drain the bladder or to instill diagnostic or therapeutic agents. Draining of a urinary bladder may be required secondary to bladder outlet obstruction or neurogenic bladder. Catheterization also facilitates an accurate measurement of urine output over time, post-void residual volume, and allows for the bladder to be deflated before an intra-abdominal incision. As a diagnostic tool, urinary catheterization allows for the installation of radiocontrast dye for the purposes of diagnostic imaging. And therapeutically, catheters can be used to fill the bladder with localized chemotherapy. There are instances where you should not put in a urinary catheter. Any signs suggestive of traumatic injury to the lower urinary tract, i.e. a urethral tear, should signal you to first rule out urethral injury prior to the insertion of a catheter. Any history of pelvic or straddle trauma should be your first warning sign. And physical exam that reveals a high riding or boggy prostate, perineal hematoma, or blood from the urethral meatus should also clue you in to the possibility of a urethral injury. A retrograde urethrogram should be done to rule this type of injury out prior to blind insertion of a catheter. Shown here is an example of the commonest type of catheter used in the hospital, known as a Foley catheter. The Foley catheter's tip has drainage holes for urine in the bladder to enter the catheter and then drain out of the drainage port to a catheter bag. Built into the end of the catheter is a balloon retention mechanism that, when inflated, prevents the catheter from sliding back out of the urethra. Catheters may vary in the size of their circumference, and this is usually denoted at the hub of the catheter. This balloon is always inflated with sterile water and never saline, as the salts from saline may crystallize in long-term catheters and eventually prevent balloon deflation. As with any medical procedure, it is essential to first have the patient's consent to proceed with the catheterization. Along with this, the patient should be positioned properly. The male should be supine on a bed with adequate padding underneath for any fluid leaks that may occur, and females should be supine in the frog-leg position. It's equally important to ensure all of the necessary equipment is ready and available. It may be wise to enlist an assistant to help you. In the hospital, you'll often find pre-made catheter sets. These consist of a sterile basin, betadine-soaked swab for prepping the area, sterile lubrication, a 10 cc syringe of sterile water, as well as drapes. You'll also need to prepare your Foley catheter, a catheter bag, and don well-fitting sterile gloves. Before the insertion of the catheter, inflate the balloon with the 10 cc syringe to ensure the balloon port is patent and that there are no leaks within the catheter's retention mechanism. Begin by draping the patient as shown, exposing either the vulva or penis through the drape's window. For males, take hold of the penis with your non-dominant hand with a firm but gentle grip and gently retract the foreskin. In females, your non-dominant hand will be used to spread the labia and expose the urethra. In either case, this hand is now considered dirty and will remain on the patient's genitalia for the remainder of the procedure. Using your dominant hand, prep the urethra with the betadine swabs, starting at the meatus and working your way out circumferentially. When 3 swabs total have been done, you're ready to insert the catheter. With the penis on stretch at 90 degrees to the horizontal, grasp your well-lubricated catheter approximately 5 centimeters from the tip and insert through the meatus. The stretch of the penis is essential as it eliminates the initial curvature of the urethra, allowing for easy passage. Continue to feed the catheter into the urethra with moderate force. The catheter should slide easily with minimal resistance. Insert the catheter all the way to the hub to ensure the balloon tip is fully inside the bladder. Look for the return of urine to confirm. When proper placement is confirmed, inflate the retention balloon using your syringe of sterile water. After inflation, gently withdraw the catheter until the balloon meets the bladder neck, and ensure the catheter will not spontaneously dislodge. In uncircumcised males, you must reduce the foreskin after catheter placement. This prevents the development of paraphimosis. The final step is to now connect the catheter to its catheter bag and to clean up after yourself.